So without further ado, I'm going to introduce our first speaker, who, pardon me while I take off or just focus, who is Dr. Hack, the chair of the Movement Disorder Department at the University of Miami. And I'm not done, hold on. Sit tight. Okay, so Dr. Hack completed his neurology residency training at Georgetown University and his fellowship training at the University of Florida's Movement Disorder and Neurorestoration Program at the Norman Fixel Institute for Neurological Diseases. He was previously associate professor at the Wake Forest School of Medicine in the Department of Neurology and Neurosurgery before being recruited to the current position as division chief at Miami in 2020. So without further ado, Dr. Hack.
Well, first of all, thank you, Judy, for setting all this up and having me here. This is lovely. It's great to be among people in person again, I have to say. Thank you to APDA, and of course, can't hear? How about now? Okay, well, you've missed my thanking Judy, which I thought was pretty important. And also, I need to thank APDA. I need to thank all of you also for coming out to hear us today. So I'm starting off by talking about starting off. So they'd asked me to talk about Parkinson's disease and what medication regimens might work best for people, and a little bit about when even to start medication. There should be time for questions. Judy, will we be doing questions between the talks as well? Are we doing questions between the talks also, or just the panel? Okay, great. So I will leave some time for questions, and then we'll be all sitting together in a panel at the end of this morning segment to answer questions as well. All right, so let me start. So first off, here's what we're talking about, right? Here's where everything that we are sits, our brains. This is where our hopes and dreams live, and also our ability to control our movement. And that's what's affected in Parkinson's, among other things that we'll talk about today. It's complicated. So here's a diagram we often look at that shows all the different connections that go into, well, movement and cognition and all that stuff that we try to help folks with. These are called the basal ganglia. So these are the core parts of your brain, the switchboard that allows everything to communicate with everything else. And I put this up because this is the system that changes in people with Parkinson's disease. More specifically, what is this? So these are two slices through the brainstem of a person. One shows a person who's had Parkinson's disease for a while, and one person who has not. What the arrows are pointing at, as you'll have read already, are what's called the substantia nigra, the dark matter, that part of your brain that helps produce dopamine. Dopamine is the main chemical that folks with Parkinson's disease don't produce. And without the presence of dopamine, it becomes difficult to move. People have issues with stiffness and slowness, and of course, we'll talk more about that momentarily. And also, it can allow the system to produce regular signals that result in tremor. So this is where a lot of that change happens. It's, as I said, mostly, but not entirely, what Parkinson's disease is, this decrease in dopamine. And it takes a long time. Oh, not without breaking the speakers. So can you hear me okay like this? Yeah, I'll do my best to speak up, but the thing is, up here it's really loud, so it's hard for me to judge how loud I am for you. So just raise your hands if I end up being too quiet. Really? Okay. I can try. I have to tell you, I'm already going at half speed. I grew up in New York. And so I will do my best. All right. So loud enough, slow enough. That's what I mean. So I'll work within my limits and the limits of the system. Would you like me to do a Southern accent as well? My kids like my Southern accent. We spent 10 years in North Carolina, so my North Carolina is pretty solid. So Parkinson's takes a long time to show up. The changes that you're seeing here, well, that happens after about 80% of the neurons are gone. So Parkinson's disease really doesn't show up until the symptoms have been, well, the system has been changing for a while. The brain has a lot of reserve built into it, but eventually the system starts to show its difficulties and symptoms pop up. Actually, the first things to pop up usually are non-motor symptoms. So it's not the movement often that's affected first. So people will have had issues with slowness of movement with issues with sleeping, for example, or a loss of their sense of smell, or even depression or anxiety, long before any movement features will pop up. And one of the concepts I want to stress is that you can think of these dopamine neurons as dopamine banks, and that's going to be important for understanding some of the things I want to mention about medication. So these neurons both release dopamine, but they're also responsible for storing it. And so if we give you dopamine back, these neurons are what hold on to the medication for as long as they can. So they release what you need, but they also store whatever extra you have. And again, that's key to understanding some of what the medications do. So let's talk about what Parkinson's disease looks like. So lots of people think of Parkinson's disease as a disease with tremor, but in truth, tremor is not present in everyone. It depends on your age. We have a lot of patients that develop symptoms younger, and so people who are in their 40s, for example, with Parkinson's disease, about 50% of them have tremor. The older you are when you first develop symptoms, the more likely it is that tremor is part of them. So the numbers, I think, are around 65 to 75%. But still, a quarter is a lot of people who don't have a tremor at all, but still have Parkinson's disease. It usually starts in a hand, and it's usually more on one side of your body than the other. It's asymmetric. So, for most of the folks in the audience, we're not looking for a diagnosis at this point, but that's important for us. It's unusual for Parkinson's to be equally present on both sides at the same time. We kind of look at that to see if maybe something else is going on. It's a rest tremor. So, for example, with Parkinson's disease, if you stand up here at the lectern as I do, after you've been talking for a bit, your hand might start to shake, but then I might move to adjust the mic and the tremor would stop. That's what we mean by a rest tremor. It happens when your hand's resting. That said, resting to your brain means that you're not actively trying to send the signal to move it. So if you put your hand up here with Parkinson's disease, after about 10 to 30 seconds, your hand will start to shake again because your brain's no longer working to keep it actively moving. Stiffness is a big issue for people with Parkinson's disease. That can often be interpreted as soreness, and especially for my younger patients, their first complaint is usually something like, I think I pulled my shoulder while doing something and it just hasn't gotten better. And it's been 9 months. Slowness of movement. So it's often difficult for people with Parkinson's disease to do small movements with their hands, things like buttons, taking a wallet out of a pocket, working with credit cards. Those are often issues. This is where the gait stuff shows up also, slowness of of steps, of facial movement, all of that stuff becomes a bit more difficult when your dopamine isn't quite where it needs to be. Postural instability, I put this up here because it's something we mentioned. I'm not sure this is entirely independent of the other things I mentioned. If you're stiff and you can't move fast, if you start to tip in one direction, it's hard to catch yourself. And that's where a lot of the balance difficulty comes in for people who have it. All right. Well, that was just by way of intro, telling all of you a lot of stuff you probably already know. And so now I'm going to talk about the medications themselves. Now, these medications I'm going to focus on are almost entirely for the movement symptoms. We have other folks who are going to talk about the non-motor stuff. It's very important, but it's a different set of medications, really. So dopamine. Like I said, it's dopamine that you're missing with Parkinson's disease. So dopamine is what we try to get back, and that's things like Levodopa and Cinemed, Divi, and Ritari. The exact names don't matter to me, and I really apologize to our sponsors for saying that. But the general idea is dopamine. There are a bunch of different ways to deliver it, and that can matter an awful lot as time goes on. There are also things that are called dopamine agonists. This means they're like dopamine, but not quite dopamine, like saccharin is to sugar is an artificial compound. It mimics the actual thing, and it's very close. It's different in some key ways, which of course I'm going to describe momentarily. These are medications that are perhaps not as common as the next group that I'm going to talk about, but this includes things like apomorphine, so apopin and Kinmobi, and things like bromocriptine and pergolide, that we don't really use anymore. They're the non-ergot dopamine agonists too, still medications that are mimicking dopamine. That's things like Mirapex and Requip and Nupro. Then we have things like amantadine and long-lasting amantadine. And then we have things that affect the way dopamine lasts in your body. And I'm going to go through all this again. This is just to get everything out there in one slide, and then we'll dig down deeper on each of these. And that's carbidopa, COMT inhibitors like Stalevo or entacapone, apicapone more recently. And almost done, I promise. MAO-IBs, there's a lot to treating Parkinson's disease. We're going to go through all of it today. Selegiline and rasagiline. Okay. Artane is also perhaps worth a mention. So levodopa, this is where I'm going to spend the bulk of my time because this really is our workhorse to treatment of Parkinson's disease. It would be highly unusual for a patient with Parkinson's to go through their entire journey without at least touching levodopa, so that's why I want to stress it a bit. It is far and away our most effective treatment for Parkinson's disease motor symptoms. Why am I mentioning this? This is going to be important for talking about some of the features of dopamine's use. It's absorbed in your small intestine, so you swallow it, it breaks down in your stomach, but it doesn't do anything until it gets into your bloodstream from your gut. Now, I mention this because a lot of patients come to me asking, well, do I have to worry about whether I eat with my medication or not? Because folks will have heard, wait a couple hours. And this is the explanation for why that is. If you've got protein trying to get into your system, it's going to try to get in through the same routes that the protein and dopamine will try to get into the same routes of your small intestine. So it's kind of a traffic jam situation. If you need every bit of your levodopa to get in at once, if you really need all that medication to hit at once, protein will slow down its absorption. And so protein can make it so it's kind of like you're turning the key in your engine only halfway instead of all the way. It just may not turn on because it's partially blocked. Now, I'm talking about this because the question comes up, but to be fair, my topic is what medication do you start with? Unless you're diagnosed really late in the course, so you've already had Parkinson's for a while and just hasn't been recognized, protein effect is really unlikely to be a problem initially. When you take dopamine initially, you don't need it all to hit at once. Small amounts will probably be enough. And so at that point, protein probably isn't an effect. So in summary, for protein effect, what I usually tell patients is it doesn't matter until it does. So if you're curious, you can always just avoid protein until, say, the dinner meal and see if you have a better day on your levodopa. If you do, well, it matters. And if you don't, it doesn't matter yet. And it may never. But for some people, protein matters an awful lot, like I said. All right, so this is something that people also worry about a lot. Does taking medication early actually damage my neurons? This is an idea that's really out there in the community, or at least used to be there. It's disappearing a bit. The idea that if you start medication early, it potentially does bad things to your brain, and or if you start medication early, it won't work for as long as if you wait to take it. So what's this based on? I mean, there's this idea that dopamine does produce these compounds that potentially can damage neurons in the long term, but the doses that it takes to do this, I mean, it's not something any human will ever take. These are based on rat experiments. Similarly, if you're concerned about the possibility of dopamine actually causing damage to your brain, I'm glad to say the evidence is overwhelmingly that it does not. So take your medication with a clean conscience. There's actually some evidence that starting medication early might actually be neuroprotective. I don't think I buy this entirely, but this is something that used to float around out there. As I'll get into later, medication does great things for your symptoms, but unfortunately, it doesn't really change the disease one way or the other. It doesn't make it faster and it doesn't make it slower. It just makes you better. All right. People do develop motor fluctuations as time goes on. So although you can start levodopa again with a clean conscience, as time goes on, remember I said dopamine neurons are banks. If you have fewer of those neurons as time goes on, you have less bank, and so it's harder to hold on to your levodopa as it compared to before. It should still work well, but say, instead of lasting for 8 or 9 hours without even noticing that it wears off, maybe now it lasts 6 or 5 or potentially even for many of my patients who've had this for say 10, 15, 20 years, it may only last 2 hours or so unless we do something in addition. I'm going to talk about some of those strategies to make the medication last longer. And we call that on-off fluctuation because when you're on the medication, it feels like the lights are on. And unfortunately for a lot of people, when the medications aren't working, it can feel like things are off. I mentioned protein effect. That's one of the reasons why things can be delayed in terms of turning on. So the absorption depends on your stomach, getting through your stomach and getting into your intestine. And like I said, the protein can interfere with that process. I'm not going to dwell overly on dyskinesias. Whoops, sorry. Finger hit the wrong thing. Overly on dyskinesias unless that comes up in the questions, but the short of it is there is the potential as time goes on for you to be receiving more dopamine than your cells can absorb at any one moment. That's how I'd explain it. And so if you think of it this way, the dopamine gets your body moving. More dopamine than you can use at that moment may make your body move extra. And so later on in Parkinson's disease, it can happen that while your medication is working, if you can't absorb the extra part you're not using, it'll cause some additional movement, and that's dyskinesia. Also dystonia, although this is more of an off thing typically, so people can get issues with cramping and tightness. This is not an issue that the medication is causing. This is typically an issue the medication is failing to make better. So this is a diagram that you'll probably see again today that runs through what I was trying to impart. Initially, the medication, as it goes up and down in your system, because you know, the medication gets into you and then slowly wears out of you, then you take your next dose and it goes up. And that's what this up and down cycle is, the medication level in your blood. Initially, can you see my arrow? Yeah. Initially, this is the window where you're feeling good. You know, your neurons hold on to it. They take up any extra amount. And so you don't really feel the symptoms. As time goes on, unfortunately, that window becomes smaller. And so we have to do more to make sure that you neither have too much nor too little medication in your system. And that's what these other medications are touching on. The first and easiest thing one can think about doing when you're talking about dopamine is keeping it from leaving your body. Like I said, dopamine's there in your blood once it's absorbed through your intestine, and then it works for however long it works. It breaks down slowly, and this is not something I plan to test you on. This is just, the point is it breaks down, and it breaks down in two ways, and we have ways to slow down both of those pathways. So one is with, oh, actually, I'm going to skip past this. Oh, I thought I had, my slides are not quite out of in the order I wanted. I apologize. So what I'll say is then that we have entacapone, things like Comtan or apicapone that can slow down the breakdown of your medication through one pathway. And that's included in medications like Stalevo, which some of you will be familiar with. And you can also take things like Azilect or Rasagiline. Those are both, and that stops the breakdown of dopamine by another way. In other words, you take your dopamine, and initially it just lasts until your next dose. When it starts not to, when you start to experience wearing off, there are medications you can add on, like Comtan, like Rasagiline, that will make it last a bit longer, about half an hour to an hour per dose for most people. Now, that's one big class of medications, Levodopa. That's the workhorse for us. But we also have dopamine agonists. And this is what I said before, was sort of like saccharin is for sugar. It's an artificial compound that does a lot of the same things that dopamine does, but not exactly the same stuff. It's got some advantages, some disadvantages. So there's Apokyn, for example. This kind of dopamine agonist is relatively rapid in its action. So Apokyn kicks in very quickly, but also wears off relatively quickly as well. So it's great for when you need a boost, but it's not typically going to be very helpful for maintenance therapy. For the injectable, for example, you'd probably have to take it every half an hour or so. It also exists as a formulation you can put under your tongue, which is wonderful. Again, if you need a quick boost, Apokyn is potentially an answer, but it's not going to be the sole medication that you're managed on for the vast majority of people. Now, these are the ones that we use more commonly for maintenance therapy, so things like Mirapex, Requip, and Nupro. They are very, very similar. So if one doesn't work, you can try another, and it has about as good a chance of helping. Nupro is unique in that it's a patch and not just a pill. But all these last longer than carbidopa levodopa does. So they bind to a different part. They touch that receptor that dopamine activates a little bit differently. Like I said, it's not dopamine, it's like dopamine. And so the main advantage of these medications is they can, well, last. They have once a day formulations. Like I said, there's the rotigotine patch that just, you stick it on and then hopefully you can forget about it until the next day when you swap it out for another one. So they help a lot with on-off fluctuation, but potential problems, its disadvantages. Again, there's this idea out there that, that if you delay taking medication, You'll potentially delay side effects. That doesn't seem to be borne out by studies, but that is one reason that people will start agonists early on. I think the main reason to start it early on is potentially just its convenience. If you want to be on once-a-day medication, I mean, agonists are your main choice. Their side effects are a little different than levodopa. I didn't dwell on it, but levodopa mostly is responsible early for things like nausea, but is otherwise pretty well tolerated by people. This is typically well tolerated too, but there are some extra things. It's more likely to cause stuff. The stuff is not bad, doesn't happen to everyone. All these things I'm talking about, maybe 1 out of 3 to 1 out of 5, but for what it's worth, it can cause some leg swelling. It can make you feel more cognitively clouded. It can make you feel sleepy. For about 10% of folks or so, it actually causes behavioral changes also. So whenever you put someone on any of these, you also have to make sure to let them and their partner know that if they start doing things like gambling or other compulsive things, that may be an effect of the medication. And that's something that can disappear if you decrease the medication dose. So it's really important to recognize that if that's happening. Just like dopamine, this can cause dyskinesias. So, it's not unique. Levodopa is not unique in its potential for causing those. Agonists can too, but agonists are a very useful tool. And I mentioned apomorphine is available as an injectable. I need to update this slide. It's an under the tongue also. This I mentioned, I get these slides out of order. So entacapone is a way to make your medication last longer. Don't need to go through all of them except to say that ipicapone is nice and that it's now a once a day, whereas entacapone had to be taken with each dose. And they extend your dose of levodopa or your natural dopamine, right? You're always making dopamine yourself too, besides what we give you, for about half an hour to an hour. Side effects, I mean, it's more medication, essentially, so they can cause dyskinesia as well. Not much different to say about Azilect or Rasagiline. It's just a different pathway. It also allows your medications to last longer than they would otherwise. Now, I guess I remind myself here with my slide. I mean, you can use Rasagiline as monotherapy. In other words, as your only medication really early on. I mean, it keeps your own dopamine around for a bit longer. So for really mild symptoms, this is something that you can do. But I think we fairly quickly transitioned over to one of the mainstays, like either levodopa or an agonist. Occasionally, you not only have a tremor, but you have a tremor that dopamine doesn't fix. Tremor is a little more complicated, so we don't have to get into the details, a little bit more complicated than rigidity. Suffice to say that up to a quarter of people will find that their tremor just doesn't get better on our dopamine medications. Fair enough. Well, we have Artane in those circumstances. It's a medication that can be added on to get rid of tremor. And sometimes if tremor is your only symptom, you can start off with this medication instead of a dopaminergic. The only thing is it can be kind of rough on some people. So this is the medical school dictum they use to help us remember what anticholinergics can do. So I have a lot of people on this who do quite well, but I have a lot of people who take Artane and can't stay on it because it causes confusion or dry mouth or gives people difficulty with being able to urinate. Amantadine, well, this is a medication that we use, I think, primarily to reduce dyskinesia. It used to be something people would start relatively early on in a person's disease, for example, or rather, like Azilect, it can be used in that regard, but its effect is pretty weak, so you pretty quickly move on. That said, if you have dyskinesias, this is one of the few things you can take that will actually decrease them. And that can be really important, because you may be in a place where the amount of medication you need to keep you moving is also an amount that makes you dyskinetic. And amantadine can make it possible for you to stay on the amount that you need to take. So this is something you need to watch out for on amantadine. This is not in any way the end of the world. This is something called libido reticularis. You just need to be able to recognize it. If you're on amantadine and this pops up, let your doctor know. It's going to stick around, this kind of rash, until you come off of the amantadine. The rash is not dangerous to you, but a lot of patients have come to me and asked, what just happened? So this is what happens. This is a side effect of amantadine, potentially. I think 15–20% of folks or so. So now I'm going to get into actual questions that I've been asked about all this stuff. So all that was background, so you know what the main options are for Parkinson's treatment. But when should you start taking them at all, right, is an important question. It depends on the person. So what I want to stress is you take the medication when you've got something that bothers you that the medication could make better, right? If you've got a tremor, but it's not interfering with anything, you don't need to treat it. If you've got a tremor and it annoys you that it shows up when you're sitting there at the dinner table or when you're out with friends, by all means, let's treat it. So it's a symptomatic treatment, these medications. You don't need to wait for any reason to start medication. Starting medication earlier, amount is perhaps a different matter, but starting it earlier seems to have zero impact on the course of your Parkinson's disease, again, for bad or for good. So you just look at where your symptoms are at and decide if medication is something that you want to start. As I just said, any complications that arise seem to happen from the Parkinson's rather than the medications. So, and another thing people worry about, they worry that if they start the medications early, they stop working. Also not true from what we can tell. If you delay taking medication, say for 2 or 3 years, the amount of medication you take when you finally start taking medication seems to be about the same as you end up taking if you've taken medication throughout. So again, it's just about relieving the symptoms, whatever you feel is necessary. How do the medications affect the progression and the onset of new symptoms? Well, I've been touching on this hopefully consistently throughout. The medications are symptomatic. They don't have an impact on the disease course, at least none of the ones we have so far. 2 caveats. Being on medication can help you be more active, right? If you're less fatigued, less stiff, more mobile, then you can exercise, and that does slow progression. I cannot plaque exercise hard enough, as Dr. Schultz will tell you, I'm sure when it comes to her segment. Remaining physically active is probably the best thing you can do to change the course of your disease. The difference is night and day. Being on medication can also allow you to avoid falls. So if you're having difficulties with your balance, or if the way you walk is making it risky for you to, well, keep walking, then being on medication, I think, is the wiser thing to do. Falls are a bad thing and really can set a person back. This is an important one for us. This is something that a lot of caregivers ask me, a lot of patients ask me. I come to the doctor's office, how do I tell you what I'm going through? And some pieces of advice. Don't worry about jargon, right? Like, don't worry about calling them dyskinesias. Don't worry about describing it as a rest tremor. Just tell us, like, in your own words, what you experience. That usually, I think, is more revealing than anything else. So don't worry about getting it down in medical terms. Just tell us what you're feeling. It can be very helpful, is very helpful to know what's happening when. So when we're trying to figure out how best to help with medication adjustments, we're looking to see when your medication starts working, when it stops working. So really pay attention to whether you can feel it kick in, and you may not, and whether you can feel it wear off, and you may not, and when exactly that happens, and what happens when that happens. So again, you learn what kind of buzzwords we use eventually just from being around us, but try to avoid them. We should try to avoid them too. There are some things that other people may notice before you do. So dyskinesia, impulsivity, sleep disorders, these are something that someone who lives with you, who is around you, is probably going to observe before you do. So it is very helpful to at least check in with someone who knows you, to say if there's stuff that you need to tell your doctor before you go, or ideally bring someone with you. It's hard to remember all of this. So please write stuff down beforehand. That's what we do. I mean, you'll see us typing as we talk to you, hopefully with your permission. Why would you be expected to remember all of it if we can't? So lists, diaries, videos are super helpful, because you may have a symptom that you want to show us that just refuses to happen while you're in the office. Great. Well, we can see the video, and seeing it really gives us a better idea of what there is to do about it. And usually there is something to do about it. Now, here's my pitch for advocacy. There's a lot of stuff going on in the Parkinson's world, and especially some of the newer medications can be prohibitively expensive for a lot of our patients. This isn't us. This means talking to Congress, talking to your local legal folks. They don't care what we tell them about statistics. I'll tell you from experience. I mean, they'll politely listen, but what they really care about are personal stories. When you say, this is what I go through, this is what I live with every day. So please, don't hesitate to get involved with advocacy. Don't hesitate to call your lawmakers. That's what they're there for. More is also accomplished by groups and alone. I mean, that's why we're here, right? That's what APDA does. APDA makes sure that everyone's voice comes together and that these pushes happen in a meaningful way. So that's everything that I had. Thanks a lot for your time. And I'll take any questions if there are any. Any questions? Yes, please. Uh-huh. 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 Yeah. 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 I think that touches on a couple of important points. So I'm going to try to address that. Tell me if there's a piece of that that I end up not touching that I should. So first off, there are a lot of non-motor symptoms that come with Parkinson's disease. There are a lot of things that are more common with Parkinson's that don't show up for other people. Things like bipolar and just things like, I guess, monopolar depression are far more common with PD than for folks who don't. Yeah, absolutely. Is that better? Okay, sorry. So what I said was there are lots of non-motor symptoms that come with PD, and those often are as troublesome as the motor symptoms are, but they're treated with different medication. Clozaril can be a great medication, is typically prescribed by psychiatrists, and you're right that it does need to be carefully balanced. In that case, something like the patch would usually be avoided because, as I mentioned, the agonists have a bit more of a likelihood to cause mood disruptions. Yes, that's what I'm saying. The Parkinson's patch. Looks like the new pro reps heard me. My God.